Hello and welcome to this talk on venous and lymphatic systems. It's intended for undergraduate medical education. Please see the disclaimer up on the top left-hand corner of the slide. The learning objectives are stated here. You can read them at your own pace. When it comes to classifying veins, there's a certain agreed classification. We define small veins as those with an internal diameter of 0.5 millimeters with a wall thickness of approximately 0.5 millimeters. These small veins have less elastic fibrous tissue and smooth muscle than small arteries. They're more compliant. The large or great veins, for example the vena cava, have internal diameters of 30 millimeters or more. This is bigger than the aorta, and wall thicknesses of 1.5 millimeters. Again, much less muscular than arteries, and that falls into their purpose. So why do we have veins? Well, they return blood to the heart. In general, they're a low pressure system. They also provide capacitance. In other words, the veins contain 2/3 of circulating blood volume, which is an important reservoir function. Veins are innervated by sympathetic constrictor nerves, which allows, when required, increased venous return, and by increasing venous return can increase cardiac output. Gravity affects venous return because it's a low pressure system. Effectively, when we're lying flat, there's little difference from head to toe, but standing erect, gravity favours SVC return and gravity impedes IVC, or inferior vena cava, return. There are several implications from this. Firstly, veins, particularly in the lower limbs, need valves to allow unidirectional flow. We have fairly elaborate muscle pumps in our calves to allow the pumping of blood back to the heart. If we're standing for periods of time, blood tends to pool in the lower limbs. The pressure below the heart rises according to hydrostatic pressure. So for example, in the lower limb veins, hydrostatic pressure can reach up to 100 millimeters of mercury. When we stand up, we can rapidly pool up to 500 cc's of blood. If you think of the physiology at extremes, for example, geostationary orbit, if you're living in the space station, here there's lower close to zero effective gravity. And that's a bit like lying down all the time. And over a period of time, there's loss of compensatory reflexes. Fighter pilots represent the other extreme with markedly increased gravitational forces, and they require special suits to apply counter pressure to prevent them losing consciousness at high G forces. So what can go wrong with this system of peripheral veins? Well, you can have venous incompetence, typically deep venous insufficiency, which is often hereditary, more common in the elderly and associated with obesity. If you have venous thromboembolic disease, then the veins can be destroyed, they can be occluded, and the valves can be damaged. You can have an ineffective or less effective muscle pump for a variety of reasons. All this can lead to peripheral venous hypertension with pathological distension, for example, of varicose veins, which have a large genetic component. This can cause increased capillary filtration obeying Starling's forces, and you get subsequent edema, trophic changes, hemosiderin deposition, and unfortunately ulceration for some patients. Central venous pressure can be formally measured with right heart catheterization, and there's a separate video on the right heart catheterization procedure. Central venous pressure will change with posture, volume status, and your heart function. Clinically, we look at the JVP, which is akin to the superior vena cava pressure. If we're looking at the inferior vena cava, it's not as easy to identify clinically, but we can use Doppler or ultrasound techniques. The pressure within the central venous system in health approximates 0 to 10 millimeters of mercury. Now, this is a very low pressure system. Effectively, the jugular venous pulsation measures right atrial pressure because there are no valves between the jugular vein and the right atrium. So JVP has A, C, and V waves with X and Y descents, just as the right atrium does. And again, I refer you to the right heart catheterization lecture where this is drawn out. If the JVP is elevated, this implies elevated right atrial pressure. And of course, if the JVP is low, that implies either low or normal right atrial pressure. Assessing the jugular venous pulsation is one of the most important clinical tools you'll ever develop, and it's very important to practice. We like the patient to be lying comfortable at 45 degrees, and the best place to look is between the heads of the sternocleidomastoid. There are several features of the JVP worth memorising. It's not palpable, remember it's a low pressure system. It has a complex waveform, as I said, the A, C and V waves with X and Y descents. It will vary with respiration. On inspiration, the JVP will generally fall due to increased intrathoracic compliance. If we palpate the abdomen and the area around the liver, we can cause backflow of blood, so-called hepatojugular reflux. We tend to measure it in centimetres of water, which is akin to centimetres of blood above the clavicle. I'm going to briefly talking about lymphatics. Lymphatics can be considered lattice around the capillaries, and they perform very important functions, though they're not as often talked about. The purpose of lymphatics is to return interstitial fluid to the venous system, and in the 70 kilogram male this can be up to 8 litres per day. There are several other functions, however. It trains proteins and particulate matter, including pathogens. The regional lymph nodes focus immunological function and act as a ferry system for immune cells. The lymphatic system is essential for absorption of fat from the gastrointestinal tract. Lymphatic drainage is fairly complex, and I've outlined it down here. Effectively, lymph from the lower extremities enters into the thoracic duct and then into the venous system at the junction of the left internal jugular and subclavian veins. From the left side of the head, arm and chest, it goes directly into the thoracic duct. Lymph from the right side of the head, arm and right thorax go into the right lymph duct and then into the right subclavian and right jugular vein. We have small lymphatic vessels everywhere except in the central nervous system and in the cornea. And these are one-way tubes formed by a single layer of endothelial cells on an incomplete basement membrane, thus allowing passage of lymph. Because it's a low pressure system, it makes sense that you'd have valves, and there are valves. And what you're hoping is that lymphatic pressure will be less than interstitial pressure, and that will favour transit of lymph back to the venous system. There's an elaborate structure of anchoring filaments to provide a firm attachment. Thus, the small lymphatics join to form collecting lymphatics. The afferent lymphatic trunks facilitate the flow of lymph to the lymph nodes. And like many other organs, you have afferent and efferent systems. Peristalsis occurs within the lymphatic system to favour one-way transit. When it comes to clinical examination, you'll learn that lymph nodes are grouped in chains, and there are several chains throughout the body. There's a high concentration of lymph nodes within the GIT. As I mentioned, lymphatics have to have valves because they're a low pressure system. So what's lymph made of? Well, one way to remember it is by the acronym PEC, P-E-C. P for protein, and on average, the amount of protein is less than in the plasma. E for electrolytes, and because you've got large gaps between the extracellular fluid and the lymph tissue, it's no surprise to know that the extracellular fluid electrolyte levels are similar to that of lymphatic drainage. In other words, extracellular fluid is very similar to lymphatic tissue fluid. We transfer cholesterol and phospholipids and neutral fat from the gastrointestinal tract as chylomicrons. And then finally cells. We have lymphocytes, macrophages and granulocytes, and this belies the very important role that the lymphatic system has in the management of infection and the mediation of inflammation. Lymphadenopathy means an enlarged lymph node and is a very important clinical sign, and one which you will be looking for when you begin your clinical course. Lymphadenopathy can occur if there's inflammation or infection, or if there's a primary cancer of the lymphocytes, so-called lymphoma. You can also get lymphatic spread of malignant tumours, and this will be one of the more common causes of lymphadenopathy. What happens if lymphatic drainage becomes obstructed? Well, if you have a tumour metastasizing to a lymph node, this can cause obstruction, or occasionally nodes are removed as part of surgery. A very good example of that is in breast cancer, where typically women would undergo excision of the tumour and also a wide lymph node dissection. When this happens, lymphatic drainage is impaired and they may end up with lymphedema, chronic swelling of the affected limb, typically their left upper limb. Lymphatic tissue, not in this part of the world, but typically lymphatic tissue can be infiltrated by parasites, and this causes a syndrome called elephantiasis, which can be caused by several different pathogens, often of a mosquito vector. So this has just been a whistle-stop tour of the structure and function of the venous and lymphatic systems. There are many similarities, but there are very important differences. Alterations in function in either can be primary or secondary, and once we understand the physiology, it'll facilitate a better understanding of the pathology which can develop as a result. Thank you for listening to my talk. Please feel free to check out the other content on YouTube.